Thank you for giving me the opportunity to present the results of our startup trial. We have no affiliations to disclose. Parkinson's disease is one of the most common neurological conditions with ever-increasing numbers worldwide. The causes of Parkinson's disease is a loss of nerve cells in the substantia nigra part of the brain, leading to a reduction in the chemical dopamine. Dopamine is responsible for many of the symptoms of Parkinson's. Often, these symptoms involve slow movement, rigidity, tremor, and these are the ones people think about. But there are many others, often hidden, such as those that affect the bladder. Urinary symptoms affect about 38 to 71% of people with Parkinson's and are primarily storage, with nocturia, frequency, urgency, and urinary incontinence. Very few effective treatments and little research in this area, despite the symptoms having a significant effect on quality of life. The tibial nerve is a mixed nerve containing sensory and motor fibers of L4 to S3 and originates from the same segments of the spinal cord as the innervation to the bladder. There's some evidence that stimulating this nerve with low frequency pulses at tolerable intensity can potentially treat storage symptoms. Although the exact mechanism is not fully understood, it is thought to increase the inhibition of the spinothalamic neurons within the spinal cord, reduce firing input into the pontine micturition center, which in turn inhibits the information facilitated by those nerves to the bladder. Percutaneous stimulation, i.e. use of a gauged needle, or transcutaneous, i.e. using a sticky electrode just behind the medial malleolus, are the primary methods of delivering the stimulation, produced by a small handheld unit. There is moderate quality evidence relating to subjective cure and improvement for the use of percutaneous tibial nerve stimulation in idiopathic overactive bladder. Parkinson's, there are 2 small studies looking at percutaneous tibial nerve stimulation and 3 on the use of transcutaneous tibial nerve stimulation, all of which have show some improvement with the use of the stimulation. However, startup is the first fully powered randomized controlled trial in the use of transcutaneous tibial nerve stimulation in this book. So our objectives were that we wanted to see if transcutaneous would reduce lower urinary tract symptoms in people with Parkinson's significantly more than placebo. And this is just a picture of the device that we used, and details of the methods used are outlined in the abstract. Study population were quite broad in that people had to have Parkinson's and urinary dysfunction. We had 2 primary outcomes, the ICIQ short form and the IPSS. Our secondary outcomes were varied with the Caledonian PDQ and of course the bladder diary, and we monitored compliance and use as well. Our sample size then was based on the IPSS with a minimally important difference of 3 points with 90% power. As you can see from our recruitment graph, throughout the study we recruited ahead of target, and really this shows or indicates that people with Parkinson's are really keen to try and get some sort of treatment for this condition. Our analysis then was an intention to treat. The methods then, participants attended for 1 clinic visit, during which they were consented, randomized and shown how to use the device. They were also provided with written instructions and a DVD, and they were then telephoned weekly to make sure that they had no problems and just to find out how they were getting on and give them a bit of additional support. The outcome measures were at baseline 6 and 12 weeks. The intervention and placebo used the device 2 times a week for 30 minutes for 6 weeks. As you can see at baseline, both groups were fairly similar. And looking at our primary outcome measure then, you can see from the chart that the only significant difference was in the IPSS at 6 weeks, which was significantly different, but not necessarily clinically significant difference, as looking at it was only a change of 1.49, and for a clinically important change it is thought that it should be 3, but this was right enough based on a different population. This is again just showing graphically the change in the IPSS, and you can see that both groups did improve in these two primary outcomes, but and then regressed back at 12 weeks. But there was this important difference, potentially important difference, at 6 weeks. Secondary outcomes, there's no significant difference. In the bladder diary, there's no significant difference either. You can see from the micturition episodes, urgency episodes, and daily leakage episodes that although they did improve, both groups improved. Although it's a relatively cheap intervention, in fact there's a cost of 148 per point improved in the IPSS score. Our participant experience and people liked to use it, found it very easy to use, and indeed would recommend it for other patients to use it as well. And we had compliance was really high, and the average was about 5.6 in the stimulation group, 5.8 hours of use out of 6 hours in the placebo group. There were very few, no in fact, adverse events related to the use of the device. So in conclusion, there was a significantly better or lower total IPSS score at 6 weeks in the intervention group compared to the control group, although this fell short in the thought that the clinically meaningful improvement defined as 3 points. There's no significant difference between groups in any other outcome measure at any time point. The subgroup analysis did demonstrate a trend towards greater benefit in men over 65, and this was also cost effective with lower cost. So potentially it may be of benefit in some patients within this population, and further research is required. Thank you.